Good morning, my name is Dr. Manu Bora. Today I am demonstrating ACL reconstruction with fiber tape internal brace using generation 2 tightrope party with fiber tape ligament augmentation. So as you can see, there is a complete ACL tear. You can see there is a good anterior drawer. There is a good Lachman test is coming with good anterior translation of tibia, and there is no endpoint. Endpoint is very mushy. So we will be taking out the graft. We will be taking out only one hamstring tendon semity because for the internal brace all inside ACL reconstruction we need not to take two graft. Only one tendon will be sufficient. So I will be palpating the tibial tuberosity and giving an incision to take out the semity. So I will be placing the curved scissor on the tibial shin medial surface, and then I will be going upwards like this to erase the attachment of semity. We have to identify the tendon and then
90-degree forceps.
put a ethibond loop over the semity tendon. So we have detached the semity from the tibial shin, and then there are generally three bands of semity which attaches. So we have to cut all the three bands, and most of the bands, all the three bands are generally on the inferior surface, the distal surface. So you just have to slide the scissor in so that you cut the bands, and then you feel that the semity is free. I always put my finger to check if there is any band left or not, or if we have removed all the bands. If you leave the band intact and you put a tendon stripper, that you might prematurely cut the graft. So it is very important that you check that all the bands are removed, and there are generally three bands of semi T tendon. The most advanced tendon stripper, this is a atraumatic tendon stripper by Arthrex. So when I strip the tendon by this stripper, we cut a minimum amount of muscle. Otherwise, the muscle fiber loss is big if we use a normal stripper. So we will be using a Arthrex non-traumatic tendon stripper. As you can see, the amount of muscles fiber which have come is negligible. In the normal tendon stripper, this amount of muscle fiber come along with the tendon. We will be using only one tendon for the ACL reconstruction, graft link technique, in which only one tendon is used. As you can see, there is a complete absence of ACL, so I am going to prepare the notch with a shaver. So we are going to remove the ACL remnant. There is some femoral attachment of ACL is still there, so we are going to. It is very important that you clear the notch very thoroughly, and you should be able to identify the posterior border, because your femoral tunnel should be posterior. If you by accidentally or by mistake makes a femoral tunnel which is anterior, then you will end up in a vertical ACL which will lead to failure later on. So it is very important that you clear the notch thoroughly with the shaver and you identify the posterior border of the notch. This is a graft link method. Only one tendon is used and we have quadrupled it. There are two stitches over the femur and we will put one stitch on the tibial end. The size of the graft generally comes between 8 to 10. As you can see, we have used generation 2 tightrope party which has tapes, and it comes with a loop which is also of suture tape. And on the tibial side also we have ABS loop generation 2, which is a tape device. So we have used this implant. This is the ABS implant for the tibial side. We take the measurement, the diameter of the graft, 8. 8. The measurement of the diameter of the graft is 8. We'll cover the graft and then make a tunnel. We will insert the femoral zig and hyperflex the knee. And in this femoral zig, we will place it on the posterior cortex. And I will just do a marking with a simple guide pin. So we will not go completely inside, just a marking. And then I will be checking my marking whether we are correct or so. We can see that it is around 10:30, 11 o'clock position. It is around 2 o'clock position. So we can take it a bit lower. So as we can see, it is between 1:30 and 2, and I would like to take a bit more around 2 o'clock position. So I can change my position in the final drill. So as you can see, this was 1:30. So I will place my guide like this to make it 2. So we will be like very precise in this is a diamond pin spade pin, and we'll be drilling it through and through and coming out of the lateral cortex of femur and will come out of the skin also. So after putting the guide pin, we'll be rimming the femoral tunnel. It is very important to see the cartilage while inserting the rimmer so that you don't damage the patellar or femoral cartilage. If your working portal is fine, you will never damage the cartilage. If your working portal is more medial, then you might damage a femoral condyle cartilage, and if your working portal is very proximal, you might damage the patellar cartilage. Yeah. I will be making tunnel of around 30 mm. We generally drill the tunnel length should be between 25 to 35 mm. And if you feel that the femoral cortex has come, then don't drill it. Otherwise, you will blow out the tunnel. We will be passing a acetone loop in the femur tunnel. As you can see, the position of the tunnel is very good. It is anatomical. You can see it is very posterior. There is only very thin layer of posterior cortex is left, which is 2 mm, and there is no blowout, and it was very anatomical. Now we will be making tibial tunnel by flip cutter because we are doing all inside ACL reconstruction with internal brace. So I will be using a flip cutter to make the tibial tunnel. We are using flip cutter 3. In most of the cases, because this has a avulsion fracture, in most of the cases you will find a lateral meniscus. So our zig should be, there are 2 horns of the lateral meniscus. One is posterior horn, one is anterior horn. So our tibial zig should coincide with the anterior horn of the lateral meniscus, but as there was an avulsion fracture and we can't see any meniscus here, placing my tibial zig, and this is around 7 mm far from the PCL. So either you can take a PCL reference or you can take a lateral meniscus reference. When the lateral meniscus is distorted because of the fracture, we have taken a PCL reference. The tunnel length should be around 45, and I take around angle of my zig is around 65. So this is a flip cutter 3. After measuring the tibial tunnel length, we are inserting the flip cutter 3. After inserting the flip cutter 3, you should tap the sleeve inside the bone, and then you have to flip it for the desired number of diameters. So we have flipped it for diameter 8, and then you need to retrograde drill. You have to retrograde up to 30-35 length. Flip to 3 को तो चला के ले जा सकता है, पर then again unflip it and take it out. चला के लेगा and then we can place a breathe pin with the ethibond wire. Now this is a very important step of surgery. You need to take both the lobes together in the knee. So I am taking the femoral loop and I am going to take the tibial loop as well. And then we will retrieve both the loops into the joint and then again take them out. Why we have done it? Because there should be only one soft tissue exit, otherwise your graft might impinge when you insert the graft from the medial working portal. So there has to be no soft tissue bridge between these two loops. That's why these two loops should come out from the same soft tissue hole. So we are taking the white and blue threads of the femoral button into the loop. As you can see, this button is not vertical, so we can only pull the blue. Then we have to flip the femoral button over the femoral cortex. We can check like this if the button has flipped or not. Now the button has flipped. After flipping the button, we need to shorten the femoral loop. There is one more important step, that we need to pull the fiber tape through when we are doing the shortening. We have to keep pulling the fiber tape when we do the femoral shortening, otherwise fiber tape can impinge between the femoral button and the femoral cortex. And we will be doing the femoral shortening slowly. Take the graft inside up to the second mark. Once the graft is inside up to the second mark, then we have to take the remaining thread into the tibial loop. So as you can see now, the ACL reconstruction has been done. There is a fiber tape internal brace, this is a graft, and it is very anatomical. It is very important to clear the soft tissue around the tibial hole, because if the button sits over the soft tissue necrosis will happen over time and the button will get loose and the graft will get loose. So it is very important that the graft should sit over the bone. So you need to clear all the soft tissue, all the attachment, and expose the bone around the hole. We are using tightrope ABS button, round concave 14 mm. In revision cases, we can use a bigger button. To insert a button, there is a fixed sequence. First, you load a fiber tape in the button. So there are four holes in the button. 2 holes are closed and 2 holes are open, slotted. So I will put a fiber tape in the closed and then insert ABS loop into the slotted holes, which are open holes. As this is a generation 2 implant with tape, there is some difficulty, but you will eventually learn with practice. This loop comes with a pre-loaded fiber wire so that it doesn't get shortened prematurely. To shorten the button has to come on the end of the loop. Don't shorten the loop when the button is here. So it is very important that you take the button to the end of the loop. So we have taken both the fiber tapes and the ABS loop from the button. My fiber tape should orient like this, not orient like this. So the fiber tape orientation should be horizontal, not vertical. So I will tell my assistant to hold the fiber tape horizontally like this, and between his hands I will do the shortening. If I am between his hands, the button will not come out while shortening. So that's how we do the shortening. So now the fiber tape orientation is also horizontal and we have done a complete shortening. After doing the button shortening, we will do range of motion to make the graft flex. So by this step, we are putting stress on our newly reconstructed ACL and making it lax. Once we have achieved the laxity, then we can again tighten, because both are adjustable loops. So now we have achieved the complete. I will pull out the fiber tape and we will check our ligament again to see if everything is fine. Now the amount of stretched ligament in all inside reconstructive internal brace is far better than other techniques. Why? Because we have made the ligament very lax and then again tighten it multiple times. So you can tighten the loops again and again till you get the desired. So now the ligament is very taut. So that these kind of taut newly reconstructed ACL ligaments can only happen in all inside technique when we are using both femur and tibia adjustable loops, so that we can keep on tightening it till we get the desired tension. Now it's time to fix the fiber tape. So it's very important that you fix the fiber tape with swivel lock. Never tie the fiber tape on the button. Why? There is a specific reason. If you tie the fiber tape on the button, due to the constant stress over both of the buttons, because the ligament and ACL is very tight, there is a chance that the tibial button might migrate proximally due to the creeping, and if it migrates proximally, you will get the graft laxity. So it is very important that you fix the fiber tape below the button through the anchor, so that it doesn't migrate proximally, and the fixation of internal brace should be separate from the fixation of ACL. To put the swivel lock, we have to make a drill. So I will be making a hole with a spade tip. This is a spade tip for swivel lock. This is a spade tip drill bit. Then we will be making a tap. The swivel lock should be around 1.5 to 2 centimeter below the button. खोलो इसको. Load the swivel lock anchor with the fiber tape. So you have to keep the fiber tape in tension, and you have to keep the leg in complete extension. It's very important. You need to put a gown or a rolled sheet below the ankle so that the knee is in complete extension. Don't fix the fiber tape with the knee is in flexion, otherwise FFD will develop. When I am tapping, your assistant need to loosen up the fiber tape so that the swivel lock goes inside the bone, and once it touches the bone, then you can screw it. Dila chhod. Yes, sir. Section. So this is how once again we can do cycling. After the fixation of fiber tape, you can do cycling again, and then again tighten the loop. Now the all inside ACL reconstruction in fiber tape interface is complete. Now you can see it is very stable. There is no anterior drawer. The knee is very stable. We can't find any laxity. The latchman is negative. Surgery is done.